In this class, we'll discuss about one of the topic of adrenergic system, that is sympatholytics. So in the previous class, we have discussed about sympathomimetics. So these are the drugs which mimic the action of sympathetic nervous system. So let us see the sympatholytics. That is, we can also say that they are called as adrenergic agonists, adrenergic antagonists. So let us see the mechanism of these drugs or pharmacology of these drugs. What are the sympatholytics? The sympatholytics are the drugs which block the action of both alpha as well as beta receptors. So in the adrenergic system, we saw three types of receptors: alpha adrenergic, beta adrenergic as well as dopaminergic receptors. But when coming to sympatholytics, only alpha and beta antagonists are more clinically used rather than the dopamine receptors, because dopaminergic blockade in the peripheral nervous system is not that clinically important, or we can say the blockade of these dopamine receptors in the peripheral nervous system will not take place. When coming to central nervous system dopaminergic receptors, these are blocked by the action of antiemetics, tricyclic antidepressants as well as the various other drugs. So here the blockade of adrenergic receptors by noradrenaline, or else we can say the blockade of the adrenergic receptors with the antagonist instead of noradrenaline and adrenaline. So here the noradrenaline and adrenaline are the neurotransmitters which are released in the adrenergic nervous system. So directly or indirectly, if the release of these neurotransmitters is inhibited, then the blockade action of sympathetic nervous system will take place, which is the ultimate motto of these drugs. And we can also say that these are the drugs which antagonize or which show the opposite action of adrenergic agonists. So as these are sympatholytics, they obviously show the opposite action of sympathomimetics. And here the we can say one of the characteristic feature of these antagonists is that we are saying the blockade. So how the blockade is taking place? So they just occupy the place of or else they occupy the receptor place on the receptor instead of noradrenaline or adrenaline, or we can say norepinephrine or epinephrine. So here when they block or else when they occupy the place of noradrenaline or adrenaline on the receptors, they just block the action of these two neurotransmitters, but they never show signal transduction which is shown by these neurotransmitters. So here we can say clinically there are two distinctive groups, as dopaminergic receptors are not clinically dopaminergic antagonists are not clinically used here as sympatholytics. So clinically only two antagonists, or we can say two categories are important, that is alpha as well as beta adrenergic blockers. And here the effects or else the sympatholytic effects differ based on the drug which is binding to the receptors, or else we can say the drug selectivity towards the receptors. So if a drug is binding to alpha receptors, we can say it is an alpha antagonist. If it is binding to the beta receptors, we can say it is beta antagonist. So based on the selectivity of the drug towards the receptor, the drugs are categorized. As I said, the peripheral nervous system dopaminergic receptors are not clinically important, whereas the blockade of the central nervous system dopaminergic receptors by the drugs like antiemetics, antipsychotics and tricyclic antidepressants shows the sympatholytic effect. Let us see the classification of these drugs, how these sympatholytics are classified. So basically these sympatholytics or adrenergic receptor antagonists, they are classified into two types. One is alpha receptor antagonist and the other one is beta receptor antagonist. These alpha and beta receptor antagonists are further classified as the non-selective group as well as selective group. What are these non-selective and selective? So in alpha receptors, we have already discussed that alpha receptors are of three types, 1, 2 and 3. Whereas beta receptors are also of three types, beta 1, 2 and 3. So the selective adrenergic or as the selective alpha receptor antagonist will bind to only particular alpha receptor. Like if a drug is binding to alpha 1 receptor, we can say it is a selective alpha 1 receptor antagonist. Whereas coming to non-selective drugs, these are the drugs which bind to all the three alpha receptors. The same is applicable to beta receptors also. Let us see the classification of alpha receptor antagonists. So what are the drugs which come under this category? So these alpha receptor antagonists, I told you they are categorized into two types again, selective as well as non-selective. The first, alpha 1 selective. So alpha 1 selective competitive. So what does this mean, alpha 1 selective competitive? Here the affinity of the drug towards the alpha 1 receptor is more when compared to alpha 2 receptor. So here the drugs which come under this category are prazosin, terazosin, doxazosin and tamsulosin. And when coming to alpha 1 selective competitive, these are the another category of alpha receptor antagonists where the affinity of these drugs towards alpha 2 receptor is more when compared to alpha 1 receptor. So the drugs include yohimbine, Mian Sarin and idazoxan. Let us see the non-competitive or is non-selective competitive drugs. Here we have in non-selective also we have competitive as well as irreversible. So here what does this competitive mean? The affinity of these drugs towards alpha 1 as well as alpha 2 receptors is equal. Or else we can say if a drug is binding to alpha receptors, then the affinity of the for that drug for alpha 2 receptor is also the same. But here when coming to irreversible, here the non-selective, or else we can say the affinity towards the receptor is same, but the action or else the action which is shown by this drug is not reversible. So whereas the other category of drugs, that action can be reversible. So the affinity towards the receptor is the same. So let us see the non-selective competitive drugs. It includes Phantol Amide and tolazolin, and whereas non-selective irreversible drugs include Phenoxy Benzemide and dibenzamide. Let us see the classification of beta receptor antagonists. So here also beta receptors we have non-selective as well as selective. But here non-selective and selective, it is based on the generation. We can say they are categorized as first generation and third generation. So what are these generations? It is nothing but there is a slight modification in the structure of the drug where it can show effective, or else we can say the result of the drug or else the effect of the drug is very powerful when compared to the previous generation drug. So here we can say non-selective first generation drugs include nadolol, pindolol, propranolol, sotalol, timolol and penbutalol. When coming to non-selective third generation, it includes drugs like cartilol, carvedilol, lebitalol as well as bucindolol. So here we can say the carvedilol and lebitalol. So these are the drugs which show mixed action. In the sense we can say these are called as mixed adrenergic antagonists, where they will bind to both alpha as well as beta receptors. But the affinity towards the beta receptors is more. That is the reason they are categorized under non-selective beta adrenergic third generation drugs. So here the action of these third generation drugs, or if we can say the effect of these third generation drugs is more when compared to the first generation drugs. Let us see the beta 1 selective drugs. Here also we have first generation as well as third generation drugs. First generation drugs include acebutolol, atenolol, bisoprolol, esmolol and metoprolol, as well as the third generation drugs include betoxolol, nebivolol and celiprolol. Apart from these, there are other drugs. So apart from alpha as well as beta drugs, beta adrenergic antagonists, there are other drugs which are showing sympatholytic action. For example, Algot Alkaloids. So these are the plant derived alkaloids, like it includes like ergotamine and ergotoxin. And apart from that, these are the pure alkaloids, as well as there are hydrogenated alkaloids where OH group is attached to that. For example, that is dihydroxy ergotamine and dihydroxy ergotoxin. And there are miscellaneous drugs like chlorpromazone, histamine and serotonin. So all these drugs show sympatholytic action, or as we can say, they show the antagonistic action of sympathetic nervous system. Let us see individual category of the drugs. For first category of the drugs include alpha adrenergic antagonists. Here, what happens, or else we can say what are the generalized effects of this alpha adrenergic blockade. So if any alpha receptor blockade is taking place, so what are the effects we can observe? So as these receptors are present on various locations or various organs like We can find these receptors in the intestine, in the smooth muscle, in the cardiac system, and various other GIT systems also. The effect depends on which receptor the drug is binding to, or else which receptor the blockade is occurring. So let us see the different actions or effects of these drugs on alpha blockade. So the effects on cardiovascular system. So what happens if alpha receptors on cardiovascular system gets blocked? So once if there are receptors on the alpha, there are receptors on the vascular smooth muscles of heart. So here the arterial as well as venous tone, we have the arteries and veins. So the smooth muscle, they are made up of smooth muscle. So the smooth muscle tone or else the contractility and relaxation of these arteries and ventricles will be determined based on the alpha receptor which it is binding to. For example, if it is binding to alpha receptors, it shows contraction, whereas if it is binding to beta receptors, it shows relaxation. So based on which receptor is binding to, the effect of that particular smooth muscle will depend on. And it also shows pressor effects of adrenaline is not found. So vasopressor. So vasopressor is an agent which constricts the smooth muscle. So here, in case of adrenaline, if noradrenaline is released, then it shows constriction action. But if adrenaline is released, so there will be no constriction of vascular smooth muscle. So even the effects are based on which neurotransmitter is released, and it shows posterior hypotension. And there will be also fall in blood pressure. So why does this fall in blood pressure takes place? If alpha adrenergic system or else alpha blockade takes place, then automatically the arterial as well as venous vascular tone will decrease. So if that is decreased, then heart rate will decrease, and if heart rate is decreased, then cardiac output is decreased. Once cardiac output in any case is decreased, then it will lead to fall in blood pressure. And it also causes, or as we can say, if there will be fall in blood pressure because of the alpha blockade, then it causes reflex tachycardia. So reflex tachycardia is nothing but there is abnormal heartbeat in the vascular tone, and which is determined or else which is observed because of the vasomotor center or else vascular motor center as well as alpha 2 mediated blockade. Let us see we saw the effects on CVS. So let us see what are the other effects because of the alpha blockade. So we can observe nasal stuffiness and meiosis. So nasal stuffiness is nothing but nasal congestion. So there will be block in the nasal cavity whereby there will be difficulty in breathing. And meiosis. So meiosis is a condition where there is excessive constriction of the pupil of eye. So in the eye, if the pupil it's mostly constricted, then the vision will not be proper and there will be various other eye disorders. So meiosis is one of the effect which is caused because of the excessive alpha blockade, and inhibition of ejaculation and increased intestinal motility, or we can say increased vascular tone will be increased. I mean contraction of the vascular smooth, GIT smooth muscles will be increased. It also causes sodium retention. So because of the reduced, if there is the glomerular filtration rate, or else we can say the filtration, the rate with which the filtration occurring in the glomerular apparatus, if that is decreased, because of that sodium and few other electrolyte retention will take place. So if there is any retention, then it causes increased blood pressure, and even the bladder tone or else the tone of the urinary bladder as well as the sphincter of the sphincter and prostate gland, it is also determined, or else we can say the effects on these particular organs are determined because of the alpha blockade, especially the alpha 1A sympathetic blockade. Let us see the pharmacological actions. We saw the effects, how the effects are showing. Let us see the pharmacological actions of this alpha or else we can say alpha receptor antagonist. So majorly most of the actions are there will be there will be fluctuations in the blood pressure, we can say, because the alpha antagonist, if it is binding to alpha 1 receptors, then there will be fall in blood pressure. If it binds to alpha 2 receptors, there will be fall in blood pressure. Whereas if it is binding to alpha-1 receptors, then it shows increased blood pressure because of the sodium retention. So even the blood pressure increase as well as decrease depends upon the drug binding to particular receptor. And it also shows the selectivity, it is also dependent based on the selectivity of the agent. As I told you, the selectivity towards the receptor. So these effects are based on these categories. Let us see the effect on cardiovascular system. So on the cardiovascular system, it causes fluctuations in the vascular tone. So what exactly happens because of the fluctuations of vascular tone? Here we can see there occurs vasodilatation of arteries and veins. So the arteries and veins which are present in the cardiovascular system, there occurs vasodilation. So if the dilation or else the relaxation of the vascular smooth muscle takes place, then automatically there will be decreased blood pressure as well as the decreased peripheral vascular resistance. So this is, we can say, the resistance which is shown by the vascular system towards the blood flow. So as the dilatation takes place, there will be increased blood flow. So if there is excessive blood flow, then there will be a resistance, or else we can say there is a resistant obstacle like situation which is shown by the vascular system towards the blood flow. And here even we can say the posterior hypotension. We saw the posterior hypotension is one of the effect. So this posterior hypotension condition is more in erect position than in supine position. In the sense, if a person is standing erectly, then he'll face more posterior hypotension condition when he is sleeping, or as we can say in supine position. So even the position is based, or else the position of the person also influences the blockade of these alpha receptors. And there will be the baroreflex activation. So what is this baroreflex activation? So baroreceptors, or else we can say baroreceptor reflex, it is the one of the reflex mechanism where the homeostasis of the body will be regulated, or else we can say the blood pressure, or else the flow of blood pressure in the body can be regulated because of this baroreceptor reflex. So there will be baroreceptor activation where they causes reflex tachycardia, abnormal heartbeat will be there, and also there will be increased heart rate as well as cardiac output where there will be increased blood pressure. So fall in blood pressure as well as rise in blood pressure can be observed with alpha blockade itself, but based on the selectivity towards the receptors. And it is also seen to observe there will be hypovolemia condition if there is any alpha blockade. What are the other effects? What we saw that these alpha receptor antagonists, they even show the effect on other organs like urinary bladder and various other organs, eye, nasal cavity, etc. So what happens if the blockade takes place? So if the blockade takes place in urinary bladder, then there will be decreased contraction. So if there is any decreased contraction, there will be increased urine flow. So if the contraction of the urinary bladder will not take place in a proper manner, then there will be the urination, or the urine output will be deferred. And apart from that, it shows increased insulin secretion. So insulin is one of the hormone which is released from the beta cells of islets of Langerhans which are present in the pancreas. So these insulin will regulate the glucose levels in the blood. So if excessive insulin is secreted in the body, then the glucose levels, or else we can say the glucose levels will come down than its normal level. So glucose should be maintained up to a certain level. If it is reducing, then it's normal level, or as we can say if it is reducing, then it's therapeutic index, then it leads to severe adverse effects. And it also causes meiosis. I told you meiosis is excessive constriction of the pupil of eye. It causes nasal stuffiness or nasal congestion, and it causes decreased adrenergic sweating. We can say there will be decreased sweating, which is not good for the person, because the toxins which are present in the body will come out in the form of sweat or urine. So if a person won't sweat properly, then the toxins won't come out of his body properly. What are the clinical uses? So what are the clinical uses, generalized clinical uses of all these alpha receptor antagonists? So here they will aid in reduced blood pressure. So reduced blood pressure can be observed in various situations like hypertensive emergencies, long-term treatment, as well as pheochromocytoma. So pheochromocytoma is again a condition where there will be inflammatory of the adrenal gland which is present on the kidney. So in all these conditions the blood pressure will be altered. So in order to reduce the blood pressure in all these conditions, then these alpha receptor antagonists are preferred, and they are used in vasodilatation in the conditions like peripheral vascular insufficiency, as well as to reverse vasoconstrictor excessive, if there is any excessive constriction of the vascular smooth muscle, for example in shock, or else we can say in in adverse effects of shock. So if there is any excessive constriction of these vascular smooth muscles, then these alpha receptor antagonists are preferred in order to show vasodilatation, and they even improve urinary flow, for example in a condition like benign prostatic hypoplasia. So this is a condition where there will be, we can say, there will be inflammation of the prostatic gland, where there will be the person may feel difficulty in urine. He feels to urinate very frequently, which is very difficult, or it shows, we can say, it is discomfort for the person itself. So in that condition also these alpha receptor antagonists are preferred. Let us see the adverse effects. So what happens if the dose of these alpha receptor antagonists will be in excessive amount? So it leads to posterior hypotension. So these alpha receptor antagonists show the effect of posterior hypotension. So even in excessive amount, then it causes posterior hypotension, where there will be over venous dilation because of the we can say the alpha-1 selectivity, because of less alpha-1 selectivity, because alpha-1 receptors causes vascular constriction. So here, as these drugs have less affinity towards the alpha-1 receptor, it causes venodilatation more when compared to venoconstriction. That is the reason posterior hypotension will take place. And reflex tachycardia, again the same, because the heartbeat as well as constriction of the vascular smooth muscle is regulated by the alpha-1 receptor blockade, and there will be salt in water retention. If there is any salt in water retention, then there will be increase in the blood pressure, nasal congestion, meiosis, as well as failure of ejaculation. So these are all the adverse effects which are shown by this alpha receptor antagonists. Let us see the individual drugs. So as I told you, Phenoxy Benzemide. So Phenoxy Benzemide is we can say it is a non-selective alpha receptor antagonist which bind to all the three alpha receptors. And here we can see the structure. If you see the structure, I have highlighted the structure where that position is called as cysteine position. So the cysteine amino acid is present in this Phenoxy Benzemide. So if the blockade in the cysteine position takes place, then only the action of this Phenoxy Benzemide can be observed. So let us see the mechanism of action. So if you see the blockade, previous slide, blockade is occurring at the cysteine position. So here, once this Phenoxy Benzemide, once it's entering into the body, then it undergoes cyclization reaction in the cysteine position itself, whereby it is forming an ethinylamine intermediate. So ethinylamine intermediate is one of the compounds, we can say it is an intermediate compound which is formed because of the cyclization of cysteine position in the Phenoxy Benzemide. And because of that, because of the intermediate which is formed, then only this intermediate have the capability to show the strong bonding capacity with the alpha receptors. So it will show the strong covalent bond with the alpha receptors, and thereby the alpha receptor blockade will takes place. What are the effects? So if this Phenoxy Benzemide is an irreversible drug, we have discussed in the category, it is an irreversible non-selective drug, Phenoxy Benzemide. So this, once it blocks the alpha receptors, then the action of these alpha receptors cannot be reversible, or else we can say the action cannot be reversed. So once the blockade occurs, then that's all. The blockade occurs for permanent. So that is the reason if these Phenoxy Benzemide, we can say it is clinically useful, but it should not be used in excessive doses. So the covalent binding with the receptor, because of the covalent binding with the receptor, the action is irreversible and it has long duration of action. So once it is entering into the body, then it shows after 4 hours it shows its action, and after 14 hours it shows its action, and the action lasts for even 48 hours also. So the duration of action of this drug is for longer period of time. And not only blocking of the alpha receptors, it even blocks the 5-HT, that is serotonin receptors, cholinergic receptors, as well as H1, histamine 1 receptors also. And because of that, because of the blockade of these alpha receptors, it shows, or else we can say it inhibits the neuronal as well as extraneuronal uptake of noradrenaline. So we discussed in this adrenergic system, so once the synthesis of this noradrenaline takes place, then after metabolism and after binding to the receptors, it shows uptake mechanism. So because of this uptake mechanism, this noradrenaline is released again. So because of the alpha blockade, there occurs inhibition of this uptake of noradrenaline. If noradrenaline uptake is inhibited, then there will be no release of noradrenaline again. So this is one of the mechanism of this alpha 1 receptor blockade by Phenoxy Benzemide, and it is absorbed from GIT. So as it is absorbed in the GIT, it undergoes first pass metabolism and there will be low bioavailability. So this first pass metabolism is nothing but, if we take drug orally, when it passes through the GIT, it has to go to the liver and where metabolic reactions takes place. So if metabolic reactions takes place, then because of the product which is formed, or else because of the metabolite which is formed, then the drug becomes inactive. Or else we can say only few amount of drug is reaching the circulatory system. So if low amount of drug is reaching the circulatory system, then there will be low bioavailability and the drug action is lowered. So only the drugs which are not undergoing first pass metabolism will show faster action. For example, the drugs which are infused through IV. So if a drug is susceptible to first pass metabolism, or else we can say if a drug is undergoing first pass metabolism, then those drugs are formulated in the form of IV, where when it is given in intravenous route, there will be 100% bioavailability of the drug. Let us see the pharmacokinetics. So as I told you, it is absorbed in the gut and GIT, as well as it is given through orally only, because if it is given, or else if we recommended to give in intramuscular route or subcutaneous route, then that route will be painful, or else we can say there will be some side effects which are observed because of this route of administration. So that is the reason only oral route is preferred, as it has to be given orally, then there will be first pass metabolism and low availability of the drug. And most of the drug which is administered is excreted in the urine itself, because when the availability of the drug in the systemic circulation is low, then if we can say, for example, let us see that example, if 100% drug is there, out of that only 20 to 30% of the drug is reaching blood circulation, and remaining whatever the 70 to 80% of the drug is there, it is excreted in the urine as a metabolite, so which is of no use, or else we can say it shows lesser effect. And the dosage which is recommended, or else the dose which is given for the drug is about 20 to 60 mg orally. If we have to give IV route, I mean if it is in emergency conditions, if we have to prefer through IV route, then it is given 1 mg per kg dose for every 1 hour. Let us see the clinical uses of these drugs. So the Phenoxy Benzemide, it is clinically used in pheochromocytoma and to control blood pressure, as well as before surgery conditions, or before surgery, the Phenoxy Benzemide is recommended. What are the adverse effects? So commonly all adrenergic receptor antagonists have the adverse effects of posterior hypotension, tachycardia, nasal stuffiness, as well as decreased ejaculation. Let's see the another drug, Phantol Amide. So Phantol Amide is also a drug which is a non-selective drug, but it is competitive. We can say the action of this drug can be reversed. So it is a reversible alpha antagonist which is non-selective, as it is bind to both alpha as well as alpha 1 receptors. Here the action of this drug is very short, as we can say short acting drug. It shows its action for within minutes. So the duration of this Phantol Amide is very less, as it has only duration of action of this drug is only for few minutes. and there will be reduction in the peripheral resistance. So what is this reduction in the peripheral resistance? So because of the blockade of both, or as we can say, as it is competitive for both alpha 1 as well as alpha 2 receptors, because it has equal affinity towards alpha 1 and alpha 2 receptors, then there will be decreased, or as we can say, decreased release of noradrenaline or norepinephrine. So if there will be decreased noradrenaline, norepinephrine release, then there occurs vaso, or as we can say, venous dilation when compared to arterial dilation. So instead of arteries getting dilated, venous dilation will take place more. So this is called as reduction in the peripheral vascular resistance. The other effects of the Phantol Amide is cardiac stimulation. So there will be enhanced noradrenaline release because of the alpha blockade. So if there is the alpha receptor blockade is taking place, then the noradrenaline release will be altered, and thereby there it shows the antagonistic effect. And apart from that, it inhibits serotonin release. So we saw that few of the alpha receptor antagonists, they even block 5-HT receptors, acetylcholine receptors and H1 receptors. So here this Phantol Amide, it blocks the serotonin receptors or 5-HT receptors, and it also shows muscarinic agonist effect. Or else we can say it shows, or else it improves the parasympathetic nervous system activity. And the dose which is given, the Phantol Amide dose is about 5 mg, which is given through IV route. Clinical uses. Any alpha adrenergic receptors, any adrenergic receptors have the common clinical use of pheochromocytoma, clonidine withdrawal. So clonidine is also an adrenergic agonist. We can say it is a drug. So which or else we can say if a person stop taking this clonidine, then it leads to withdrawal syndrome. It shows symptoms like nervousness, there will be headache, severe headache, and there will be confusion in the person. So in order to treat this clonidine withdrawal syndromes, this Phantol Amide is recommended. And cheese reactions. What is this cheese reaction? So here Tyramine. So Tyramine is a compound which is formed or which is synthesized from the amino acid called tyrosine. So here this Tyramine, what does it do? It aid in the release of catecholamines. So catecholamines are nothing but neurotransmitters. So these catecholamines are metabolized by enzymes called monoamino oxidase as well as catecholamine O-methyl transferase. So here monoamino oxidase also, we have two enzymes, monoamino oxidase A as well as monoamino oxidase B. So mostly the metabolic reactions takes place through monoamino oxidase A enzyme. So here the Tyramine, because of the Tyramine, or as we can say, this Phantol Amide shows cheese reaction. Why? How? In the sense, it blocks, or as we can see, the Tyramine action is blocked, whereby there will be the blockage of this monoamino oxidase enzyme, and thereby the neurotransmitters will be released in excessive amount. So this Tyramine causes release of neurotransmitters. So if the metabolic enzyme which is metabolized in the neurotransmitter is inhibited, then there will be excessive noradrenaline release, or as we can say the excessive neurotransmitter release, which leads to adverse effects. So in these conditions, this is called cheese reaction. So in this cheese reaction condition, this Phantol Amide is recommended. And in extravasations of noradrenaline, adrenaline injection. So the IV route, or else we can say the IV route of noradrenaline and adrenaline when given, if there is any side effects which are observed because of this route, that can be altered, or else we can say that can be lowered to some extent because of Phantol Amide. What are these adverse effects? So it shows adverse effects on cardiac system as well as GIT. So in cardiac system, it shows adverse effects like tachycardia, arrhythmia and angina. So tachycardia is a condition where there will be abnormal heart rate, and arrhythmia is a condition where there will be dysrhythms, or we can say there will be disturbances in the rhythm of the heart, and angina is a condition where there occurs heart failure, or we can say the chest pain which is caused because of decreased oxygen demand to heart. And in GIT stimulation, because of the excessive stimulation of GIT, it leads to a condition called diarrhea, and there will be increased gastric acid secretion leading to ulcers in the stomach. The other drug is tolozolin. So tolozolin is a selective alpha-1 receptor antagonist, and here the actions of this toluzolin, or as we can see, the toluzolin action is similar to almost Phantol Amide, because it also shows the effects on as well as cardiovascular system and GIT. There will be decreased vascular tone as well as decreased GIT tone, but it is slightly less potent, in the sense the action, or as we can say, the effect of toluzolin is less when compared to Phantol Amide. And the better part, or else we can say the best part of this toluzolin is like it gets absorbed in the GIT, rather like when compared to the drug previous alpha receptor antagonist. So it does not undergo first pass metabolism, where it is rapidly absorbed in the GIT, and there will it is rapidly absorbed, even it is rapidly excreted in the urine, but it does not undergo first pass metabolism. It exerts its actions and then it is excreted in the urine, but it has very few clinical applications. We can say it is used in peripheral vasospastic disease. So here this is a disease which is caused because of the spasms or vasospasms which occurs in the venous blood vessels. Prazosin. So this is an alpha-1 receptor antagonist, which is we can say it binds to all alpha-1 receptor types. So in alpha-1 also we have alpha-1A, alpha-1B, alpha-1C as well as alpha-1D. So it is very selective, or else we can say it only binds to alpha-1 receptors, but it binds to all alpha-1 receptors, all types of alpha-1 receptors. And here, because of this blockade, there will be sympathetic vasoconstriction. So the blockade which is occurring because of this prazosin, it causes the decreased, or else we can say the vasoconstriction will be reduced, or as we can say the blockade of this vasoconstriction takes place in the sympathetic nervous system, and it dilates the arteries and veins. As the blockade of vasoconstriction takes place, then obviously the vasodilation takes place both in the arteries as well as in the veins, and it also inhibits an enzyme called phosphodiesterase. So PDE is an enzyme which is used in the conversion of ATP to cyclic AMP. So if it inhibits the phosphodiesterase enzyme, there will be cyclic AMP levels will be increased, and this cyclic AMP is one of the mediator which is used in the vasodilation. So here, because of the increase in the cyclic AMP levels, there occurs vasodilation because of the blockade of this phosphodiesterase enzyme. Let's see the pharmacokinetics. So this prazosin, it is effective orally, in the sense it does not undergo first pass metabolism, and 70% of the drug is it's available in the systemic circulation when it is given through oral route, and it is metabolized in the liver, and it also have T-half of 6 to 8 hours. So after 6 to 8 hours, half of the drug will be remaining in the systemic circulation and half of the drug will be eliminated, and the dose is given about 0.5 mg during bedtime. During going to bed or before going to bed, 0.5 mg of the drug is recommended. And when coming to the drug, during daytime, the drug should be about 1 to 4 mg twice a day. So twice a day should be given at the dose of 1 to 4 mg, but during night time or before going to bed, only 0.5 mg of drug is recommended to give. Clinical use. So what are the clinical uses of this prazosin? So it shows the effects, like, or else we can say it is used in hypertension because it shows the effect of vasodilation. So that is the reason it is used in hypertension condition, and it's used in Raynaud's disease. So Raynaud's disease is a condition where it causes numbness or else cool. In some areas of the body it causes numbness or cool. If we keep our hand, let's take our hand. If we keep our hand in cooler situations for longer period of time, it causes numbness. It does not show any sensation. So in that condition is called as Raynaud's disease, when this numbness occurs for longer period of time. And it is used in BPH. Again, it is benign prostatic hyperplasia. The adverse effects. So the adverse effects of these drugs include first dose effect. So what does this first dose effect mean? So this drug is effective when it is given in first dose only. For when it is given in repeated doses, this drug does not show its effects, and it shows posterior hypotension as well as salt in water retention when it is used for longer term. The other drug, the other alpha-1 receptor antagonist is terazosin. So pterojosin is almost similar to prazosin because the modification in these alpha-1 receptor blockades are in the structures. So when the structures are modified, then the effect of the drug is also modified. So this pterojosin is similar to, the effects of these pterojosin are similar to prazosin. Because of the modification in the structure, the bioavailability of the drug is more. So if we see prazosin, it is having 70% bioavailability. If you take pterojosin, it is having 90% bioavailability, where it shows more, or else we can say it shows greater effects. Whereas the duration of action of this drug is also about 24 hours. Because when compared to prazosin, the pterojosin is having longer duration of action, and it is preferred in BPH conditions, that is benign prostatic hyperplasia conditions, and also it is recommended to give in apoptosis conditions for single dose. The other drug, alpha-1 receptor antagonist, is doxazosin. So doxazosin, prazosin, pterojosin, alfuzosin. So these are all the drugs which exert similar action. Only the structural modification gives or else we can say the structural modification which is done in all these drugs either affect the bioavailability or T-half. If we see the pterojosin is having the greater bioavailability and long duration of action. If we see doxazosin, the actions are similar to prazosin, but it is having longer T-half, that is almost 22 hours. Whereas alfuzosin is as such similar to prazosin. The other drug is tamsulosin. So tamsulosin is also one of the alpha-1 receptor antagonists, but it is rather we can say it is different from all the other drugs which we have discussed. So here the drug is not, we can say the drug, it is selective towards only alpha-1A as well as alpha-1D receptors. So it is not selective, or else we can say it does not bind to alpha-1B receptor. So that this is one of the characteristic feature of this tamsulosin drug. And there will be, because if the drug is given for longer period of time also, the blood pressure and heart rate are not altered. So this is one of the best part of this drug, and it is preferred to give in BPH condition, benign prostatic hyperplasia condition, and only once dosing regimen. In the sense, the regimen, or as we can say the frequency of giving of this drug is only once a day. And the adverse effects, so it is having very few adverse effects. The adverse effects include retrograde ejaculation and dizziness when it is used for longer period of time. Let us see the alpha-2 selective drugs. So till now we saw alpha-1 receptor antagonists. Let us see the alpha-2 selective drugs. So there are two drugs which come under this category, that is yohimbine and idazoxan. So yohimbine and idazoxan, most clinically used is yohimbine. So this is only one alpha-2 receptor antagonist which is clinically used. And alpha-2 receptor antagonists are rarely used, but when compared to other drugs, yohimbine is most preferably used clinically. And the other drug is Mian Sarin. So Mian Sarin is also one of the alpha-2 receptor antagonists. It is only used in antidepressant, or we can say it is used to antagonize depression. So it is used as an antidepressant in few cases. And it also shows the actions on 5-HT receptors. It also shows the blockade of 5-HT receptors. And when coming to other drug, labetalol. So labetalol is also an alpha-2 receptor antagonist, but it shows mixed action. So it binds to both alpha as well as beta receptors and exerts both the blockade of these receptors. But selectivity of the drug towards alpha-2 receptors is more when compared to beta receptors. Let us see the comparison of the drugs. We can say the affinity of the drugs towards the alpha receptor. So if you take prazosin, pterojosin and doxazosin, these are the drugs which show the, or else we can say we categorize these drugs as alpha-1 receptor antagonists, because the affinity of these drugs towards alpha-1 receptors is highly, or we can say highly more when compared to alpha-2 receptors. And when you take Phenoxy Benzemide, when compared to prazosin, pterojosin and doxazosin, Phenoxy Benzemide, we saw that it is a non-selective drug. So, but it has a little more alpha-1 receptor affinity when compared to alpha-2. Phantol Amide, it is having equal affinity towards both the receptors. If you take yohimbine and tolozolin, so we categorize these drugs under alpha-2 receptor antagonists, as these drugs have greater affinity towards alpha-2 receptors. There are other agents which are used as alpha 2 receptors. We can say specific agents like ergot alkaloids. So these are the alkaloids which are plant derived, and these ergot alkaloids, we saw there are two drugs like ergotamine and ergotoxin. So ergotamine. So here we can say it shows partial agonist as well as blocking properties. What does this mean? It shows mixed effect, in the sense the effect depends on the dose. So if it is given in smaller doses, it shows as agonist activity. If it is given in higher doses, it shows antagonistic activity. And it also affects the other receptors like 5-HT receptors, because these are good alkaloids. All the adrenergic receptors alter some of the other receptors. So this ergot alkaloids, or else we can say ergotamine, it alters serotonin or 5-HT receptors, and there are very less therapeutic uses, like it is used only in migraine and if there is any disturbances in the uterus, and it is not related to alpha blockade. So what does this mean? It is not related to alpha blockade, in the sense it is related to beta blockade. As we can say, the blockade occurs through beta adrenergic system, or else the blockade even occurs to the 5-HT blockade also, or else we can say the blockade occurs through serotonin receptor antagonizing effect. The clinical uses, we saw it has very clinical uses. It is used in migraine and it is used as uterotonic, in the sense it increases the tone of uterus. Let us see the beta adrenergic receptors. So beta adrenergic antagonists, these are the drugs which block, or else we can say which antagonize the action of beta receptors. So what are these beta receptor blockades? So here we have beta 1, beta 2 as well as beta 3 receptors, and the location of these receptors differ from organ to organ. So that is the reason if the action, or else we can say the antagonistic action of these drugs depends upon the selectivity towards the beta 2 receptors and the location of the beta receptors where it is present. And here we can see it is caused, or else we can say it's likely to cause myocardial depression and less precipitation towards CCF. So what does this mean? So if beta adrenergic blockade is taking place, then it causes congestive cardiac failure. If it is taking place for a longer period of time, it causes congestive cardiac failure rather than a myocardial depression in damaged heart. And if you see pindolol and oxypropranolol, they do not alter, or else we can say they do not impair AV conduction. So AV node and SA node, so these are the two nodes which are present in the heart where the conduction of impulses are taking place in the heart. So here we can see these are the pacemakers of the heart where the conduction of impulses taking place. So here if pindolol, because of these drugs, especially pindolol and oxypropranolol, the AV conduction is not at all altered. And the pharmacological actions of these the generalized pharmacological actions which are shown by these beta receptors, they show only at higher doses when compared to smaller doses. Let us see the individual drug. The first drug is propranolol. So propranolol is a non-selective beta adrenergic receptor. It binds to all the beta adrenergic receptors. And here we can see the structure of propranolol. Let us see the absorption. So what are the pharmacokinetics of propranolol? So main mechanism of all the beta receptor antagonists is that they go and bind to beta receptors and thereby the blockade of beta receptor action takes place. So that is the common mechanism of action which is shown by this beta receptor antagonist. So here if we take the absorption, so once after this propranolol is given into the body, after 1 to 3 hours, then only the peak concentration will take place. In the sense, the more amount of drug which is getting absorbed is after 1 to 3 hours once it is ingested. So after the drug administered, maybe 1 hour or 3 hours depending upon the person as well as environmental conditions as well as body conditions, the absorption of the drug takes place, and it shows sustained release preparations. In the sense, there are sustained release preparations also. So what are the sustained release preparations? So these are the preparations which are available in the market where the release of the drug is sustained, or we can say the release of the drug is sustained from longer period of time. So the name itself indicates. So here we are adding some ingredients to the formulation. For example, if you take sustained release tablets, so in the tablets we are adding some ingredients where the release of the main drug, or else we can say the release of the active ingredient through the, or else from the tablet is sustained, or else we can say it is showing for longer, the release is for longer period of time. Why? Because these all beta adrenergic blockers have shorter duration of action. So they show these actions, the action which is shown by this beta adrenergic receptors for very short period of time. So that is the reason, in order to maintain the effect of these beta adrenergic receptors for longer period of time, mostly sustained release preparations are preferred when compared to normal tablets. So these sustained release preparations are can be made because of the propranolol. We can say sustained release preparation shows greater effect when compared to other formulations, and it undergoes first pass metabolism. So this is also one of the reason why these propranolol is marketed as sustained release. So in the sustained release preparations, the drug won't undergo first pass metabolism, so that the drug bioavailability is more. So that is the reason the drug is administered. That is the reason it is showing short effect. So that is the reason it is prepared as sustained formulations, and it is dose dependent mechanism. In the sense, only at a particular dose it exerts its actions. If the dose either decreases or increases, then the effects may be altered. And the parental route, I mean the bioavailability of the drug depends on the route of administration also. So here the bioavailability of the drug when it is administered orally is more when compared to IV, because of the preparation in which it is made into. Let us see the distribution of the drug. So once it is entering into the body, how it is getting distributed, or is where it is getting distributed. So it is distributed all over the body, and it shows large volume of distribution. So what does this mean? Large volume of distribution in the sense it is distributed all over the body, and the distribution is, the distribution occurs in for longer period of time, and it is large even. The more amount of drug is available in each and every organ. So the distribution, we can say it is almost equal. And the propranolol is lipophilic in nature. So as this drug is lipophilic in nature, any drug which is lipophilic in nature can cross blood-brain barrier, and it has a T-half of about 3 to 10 hours. And because of these drug, the propranolol is eliminated because of the the elimination, we can say the elimination of the propranolol can be altered based on the condition of the liver. So if the liver is proper, then the drug elimination will be proper. If there is any liver diseases, or else we can say there is any disturbances in the hepatic flow, or there is any disturbances in the hepatic enzyme inhibition, then the excretion of this propranolol can be altered. And the pharmacodynamics even affect the half-life, in the sense the absorption and distribution of the drug will determine, as we can say, they will alter the half-life of the drug. Let us see the pharmacological actions. So what are the pharmacological actions of this propranolol? So it has various pharmacological actions. For example, if you take heart, so what happens if propranolol is given to heart? So it causes decrease in the cardiac output. We can say, as this is a beta receptor antagonist, so beta receptor agonist, or as we can say beta stimulation, shows effects like increased heart rate and increased cardiac output and increased blood pressure. So as this is a beta receptor antagonist, it shows the opposite effects of the sympathetic nervous system, that is decreased heart rate, decreased cardiac smooth muscle, decreased cardiac output, there occurs decreased force of contraction of heart, and then ultimately the blood pressure is decreased, and it prolongs systole. So the blood pressure, we have systolic as well as diastolic pressure. So the systolic blood pressure is prolonged because of this propranolol, and it shows decreased ventricular size. The size of the, we can say not exactly the size. What does this sentence mean is that the volume of blood which is coming out of this ventricles may be decreased. So that is called decreased ventricular size, and the cardiac output and oxygen consumption is reduced. So we do excessive exercise or massive exercise, also the consumption, or else we can say the oxygen which is required to perform that exercise can be reduced because of this propranolol. And at higher doses it shows membrane stabilizing and direct depressant action. So when it is given in higher doses, membrane stabilizing. So what does this membrane stabilizing give? Here the conduction of impulses are taking place in the heart through the vascular muscle. So each and every cell has the membrane, or else we can say the cardiac membrane which is present, the conductivity or the stabilization of the impulse conduction in the membrane is altered, or we can say it is stabilized because of this propranolol, and it shows direct depressant action. The other effects which are shown by this propranolol is that it affects the blood pressure. I told you it causes decrease in the heart rate, decrease in the cardiac output, where there will be decrease in the blood pressure. So, but the action, or else we can say the direct blood pressure decrease is not observed. Here we saw the systolic pressure, or we can say systolic pressure is prolonged. Because of that, where there will be there will be decrease in the blood pressure. So here the mechanism by which the blood pressure is decreased is not direct, so it's showing indirect effect, but it is very useful in hypertensive conditions as it causes decrease in the blood pressure, whether it may be direct or indirect. The ultimate result is decrease in the blood pressure. So that is the reason it is recommended to give in hypertensive conditions, and it causes adaptation in the sense that the person gets adapted for that drug, or else we can say the person gets used to that drug. And the other effect shows decreased renin release. So renin is also one of the compound which is released from the liver, where it alters the blood pressure. So there will be decreased in renin release and central reduction of sympathetic outflow. So in the central nervous system, the sympathetic flow which is there, or else we can say the nerves which are emerging from sympathetic nervous system will be decreased. So what are the actions on respiratory system? So it causes bronchoconstriction. So because of the blockade of these beta-2 receptors, so if beta-2 receptors is blockade, it causes constriction of the bronchial smooth muscle. So that is the reason these beta-2 receptor antagonists are not mostly preferred in asthma patients, especially salbutamol. So salbutamol is one of the drugs which should be contraindicated in asthma conditions, because the salbutamol causes excessive beta-2 receptor blockade, where it leads to excessive bronchoconstriction, leading to synergistic effect in asthma conditions. So that is the reason few of the beta-adrenergic receptors antagonists are contraindicated in asthma. But this propranolol is not that much effective to show bronchoconstriction, and beta-1 selective drugs are preferred in the sense in respiratory conditions. That is the reason, because of this beta-2 blockade, as the propranolol shows beta-2 blockade. So that is the reason in this respiratory disorders or respiratory conditions, beta-1 receptor selective drugs are more preferred when compared to beta-2 drugs, and it is contraindicated in COPD patients, that is coronary obstructive pulmonary disorder. And in eye, so in eye it causes decreased intraocular pressure. So the pressure which is created in the intraorbitals of the eye, the pressure is decreased. Because of that, thereby it leads to a condition called glaucoma. So if intraocular pressure is decreased, then it causes, or we can say the vision is not proper, and it leads to various other eye disorders. So because of the various other eye disorder consequences, it leads to blindness. So this condition is called as glaucoma. On CNS, so this propranolol won't show us, we can say the beta receptor antagonist won't have much markable effects on CNS, but it shows few effects like behavioral effects, forgetfulness, the person will have short-term memory, and he'll get nightmares. So the nightmares can be observed in that person. And if we see the skeletal muscle, so there will be decrease in the tremor. We can say there will be decreased skeletal muscle the skeletal muscle development can be altered. The contraction of the skeletal muscle can be reduced. So this is the appropriate word we can use. The contraction and relaxation of the skeletal muscle can be altered, or we can say that is reduced, and there will be reduction of exercise capacity, as these beta receptor antagonists have less oxygen consumption levels. So it causes if the oxygen consumption is not good, then we won't be able to do massive exercise. So there will be reduction of excessive capacity there, where it causes decreased blood flow, and it causes glycogenolysis. So what is this glycogenolysis? A breakdown of glycogen to glucose. And what are the other actions? So what are the other actions of this propranolol? So propranolol, it inhibits sympathetic nervous system and its stimulation of lipolysis. So as I told you, we saw propranolol, it inhibits sympathetic nervous system activity as it is a beta receptor antagonist, but here it shows stimulation of lipolysis. So the lysis, or as we can say the breakdown of lipids is more, and there will be inhibition of glycogenolysis. In the previous slide itself we saw reduced exercise capacity, where it leads to reduced glycogenolysis because of the beta 2 receptor mediated action. And hypoglycemia conditions are very rare. So here we saw that it causes glycogenolysis. So glycogenolysis in the sense breakdown of glycogen to glucose. So here if the excessive glycogen breakdown is taking place and the glucose is forming, there will be increased glucose concentration in the blood circulatory system, where it leads to diabetes mellitus, or we can say hyperglycemia condition. So this condition is very rare, and here that is the reason beta 1 selective drugs are more preferred when compared to beta 2 selective drugs. And as I told you, it causes stimulation of lipolysis, breakdown of lipids. So that is the reason there will be increased plasma membrane, or as we can say increased concentrations of the cholesterols in the plasma. So here we have VLDL, LDL, HDL and chylomicrons. So these are the lipids which are available in the body. So when the complex lipids are break down into simpler lipids, there's like when lipolysis takes place, this VLDL, LDL, HDL and chylomicrons are formed. So because of the higher lipolysis, the increased concentration of these lipids in the plasma will be altered. What are the other actions of this beta receptor antagonist, or as we can say the propranolol? So it shows the intrinsic sympathomimetic activity. So here if the dose, as it is a dose dependent mechanism, if the dose can be altered, instead of showing sympatholytic activity, or as we can say adrenoreceptor antagonist activity, it shows adrenoreceptor agonist activity. For example, if it is showing adrenoreceptor agonist activity, so it may lead to, or as we can say, it is useful in asthma conditions, because adrenergic receptor antagonists are contraindicated in asthma. But if it is showing sympathomimetic activity, then it can be recommended in asthmatic conditions, as well as it is used to prevent excessive bradycardia. So bradycardia is a condition where there will be force of contract, there will be alterations or abnormal conditions of force of contraction of the heart. And the other one is it shows membrane stabilizing effect. So as I told you, the impulses are being conducted through the membrane which is present in the heart. So the membrane stabilizing activity, or we can say the impulses which are generating or conducted through the membrane, that can be stabilized because of the action of this, or as we can say because of the effect of this propranolol. What are the drug interactions? So when should this propranolol be contraindicated as beta receptor antagonist? So propranolol should not be given with insulin. Why? Because this, as I told you, propranolol causes glycogenolysis, where the conversion, or we can say the glycogen breakdown is taking place, whereby glucose is formed. So because of the, there will be decrease in some few situations, it may cause decreased glycogenolysis also. So here if there will be decreased glycogenolysis, the availability of glucose in the blood is reduced, and thereby if insulin is secreted, when propranolol and insulin both are given together, they causes more decreased glucose levels than to its normal level, then which leads to hypoglycemic conditions. So that is the reason it should be contraindicated with insulin, and apart from that it should be contraindicated with alpha agonist. So the actions of alpha as well as beta receptors are not the same, so they are different. That is the reason propranolol should not be given alpha receptor antagonist, because it may cause high blood pressure, or as we can say it leads to hypertensive conditions. And it should not be given in NSAIDs, so non-steroidal anti-inflammatory drugs. So propranolol should be contraindicated with NSAIDs because it causes attenuation of antihypertensive action of beta blockers. So attenuation is nothing but we can say almost extinction. So the antihypertensive activity of these beta blockers can be nullified, or as we can say they show no effect when this propranolol is given with NSAIDs. What are the adverse drug reactions? So when propranolol is given in excessive dose, it may lead to congestive cardiac failure, congestive heart failure, and it may cause bradycardia condition. There will be abnormal force of contraction of the heart, and it may cause coronary heart diseases. Or else we can say there will be blockage of the coronary arteries, or else we can say because of the deposition of the cholesterol. So the LDLs and VLDLs, it causes stimulation of lipolysis, and there will be excessive formation of lipids in the body. So when a propranolol is given in more doses, it causes increased lipolysis condition where the lipids are formed. It gets deposited in the it gets deposited in the coronary vascular muscles or coronary smooth muscles, where there will be reduced flow, or else will be increased risk of coronary heart disease, and it sometimes causes precipitation of asthma and COPD. So if it is given in excessive dose, then it leads to coronary obstructive pulmonary diseases also. Apart from that, it also causes the common effects, like it shows the tiredness, because as I told you, it decreases the oxygen consumption, thereby reducing the exercising capacity. So because of that, it causes fatigue or tiredness of the person, and it causes variant angina exacerbation, because as the oxygen consumption is decreased, thereby the oxygen demand for the heart will be increased, and thereby sometimes it leads to a condition called angina. And if there is any if the dose even exceeds, it causes the the blood pressure will be reduced. So because of that, what happens is that because of excessive reduction in the blood pressure, the hands and feet of the person will become cold. So because of this, because of the peripheral vascular resistance, or we can say the decrease in the blood pressure or else venous dilation, the cold hands and feet of the person are observed, and it causes the other effects, like there will be a GIT upset. There will be upset, or as we can see, there will be some disturbances in the GIT system, and nightmares, forgetfulness, as well as sexual distress. So these are few of the side effects or as adverse effects which are observed because of propranolol. What are the uses of these drugs? Propranolol is one of the first line beta adrenergic receptor antagonists which is used in hypertension. So this is one of the best drugs which is used in hypertensive conditions. It is used in angina pectoris as well as myocardial infarction. It is used in myocardial infarction in order to prevent the excessive fibrillation, or as we can say the excessive deposition of fibrous tissue in the cardiac tissue. So in order to prevent that, it is used in myocardial infarction, as well as it is used in cardiac arrhythmiasis as class 2 drugs. So these cardiac antiarrhythmic drugs are classified as class 1, 2, 3 and 4 drugs. So out of these class 2 drugs are beta receptor antagonists. So it is mostly recommended to treat arrhythmia and congestive heart failure, hyperthyroidism, migraine, anxiety conditions, essential tremor as well as glaucoma. So in all these conditions, propranolol is recommended. The other drug is metoprolol. So metoprolol is a pro-type of cardioselective drug. What we can say, it is pro-type of cardioselective in the sense it is more affinity, or as we can say it shows the greater affinity towards the beta receptors which are present in the cardiac system, and it is also safer to give in the patients which are suffering with bronchoconstriction. In the sense, this metoprolol can be recommended to give in asthma because it does not cause bronchoconstriction, and it has less first pass metabolism. That is the reason the oral route of administration is preferred, and it shows low and fast hydroxylation. I mean, the metabolism of the drug is also slow, and it is used in conditions like myocardial infarction, as well as it is used in diabetes conditions also. The clinical applications of this drug are diabetes as well as myocardial infarction, and the dose which is given, the metoprolol dose is about 25 to 100. I mean, the dose depends upon 25 to 100. We can say 25 mg per kg, 50 mg per kg, 100 mg per kg is recommended based on the condition of the person, and this dose is for tablets, as well as it is also recommended to give in IV route. The other drug is atenolol. So atenolol is one of the drug which is beta 1 selective. So it binds to only beta 1 receptors, and it is having low lipid solubility. We can say the drug is highly soluble in water. That is the reason it cannot cause blood-brain barrier, and because of that it is having longer duration of action. I mean, the effects which are shown by this drug is for longer period of time. That is the reason, as it is having longer duration of action, its T-half will be more, and because of the T-half, the drug should be given only once a day. And there will be as it is a, we can say, as it is a low lipid soluble drug, the lipid levels in the circulatory system cannot be altered because of this drug. The other drug is esmolol. So esmolol is also a beta-1 selective receptor antagonist. When compared to atenolol, it is having shorter duration of action, that is, it is less than 10 minutes only. We can say it is an ultra short acting drug, fast acting drug, and the steady dose can be maintained. In the sense, once it reaches the peak concentrations, the effect which is shown by the peak concentration of the drug can be sustained, and it is given through IV route as well as if the IV infusion is not given proper, then it leads to atrial flutter, arrhythmia during anesthesia conditions. So during anesthesia, if this metoprolol is also administered, then we should be very careful while giving IV route. And the injections, or as we can say, the dose which is recommended for this esmolol is about 100 to 500 mg for 10 ml. The other drug, or as we can say, the other drug is that esmolol. So esmolol is also a beta-1 receptor antagonist. So it is a very short acting drug. In the sense, the duration of action of this esmolol is less than 10 minutes. That is the reason it is categorized under ultra short acting drug, and the steady dose can be maintained. So what does this mean? Once it reaches the peak concentration, then the effect of that, the effect which is shown by this drug on peak concentration is sustained or remain for longer period of time, and it is given as an IV infusion in condition. So we can say that the IV route is mostly preferred, and it is used, or else we can say it is given in IV route in the conditions like atrial flutter, arrhythmia, and even during anesthesia conditions also. So in all these conditions, the metoprolol is recommended to give in IV route, and the available injections are about we can say for every 10 ml of the solution or 10 ml of injection, 100 to 500 mg of drug is available. So the dose is dependent based on the type of injection is dependent based on the dose of the drug available. The other drug is celiprolol. So celiprolol is the drug which is having, or else we can say it shows selective beta-1, or else we can say it is a selective beta-1 receptor antagonist. So apart from that, apart from showing beta-1 receptor antagonism, it also shows beta-2 agonism activity. So what does this mean? So if it is blocking beta-1 receptor, it is showing affinity towards the beta-2 receptors, where it is showing sympathomimetic effect. So this is one of the characteristic feature of this celiprolol, and that is the reason, as it is showing beta-2 agonism, it is used to recommend, or as we can say, it is safer to use in asthma conditions, and it causes vasodilation. So nitric oxide. So nitric oxide is one of the chemical mediator which causes dilatation of the vascular smooth muscle. So this celiprolol, it aids the cell, or as we can say, it aids to donate the nitric oxide. When the nitric oxide levels are increased, then it causes vasodilatation, and the dose of this celiprolol is about 200 to 600 mg. The other drug is carvedilol. So carvedilol is a drug which is showing affinity towards all the beta receptors, all the adrenergic receptors. We can say alpha as well as beta. So that is the reason it is called as mixed adrenergic receptor antagonist. So it has affinity towards alpha 1, beta 1 as well as beta 2 receptors also. So how does this act? So once when there will be blockade of these alpha 1, beta 1 and beta 2 receptors, then it causes the blockade of calcium channels also. So if the calcium levels are decreased, then ultimately vasoconstriction will be decreased, and there will be fall in the blood pressure. So that is the reason, that is how it is showing the antagonistic mechanism, and it is mostly preferred, or as we can say, this is the drug of choice in congestive heart failure, as it is showing cardioprotective action. The other drug is nebivolol. So nebivolol is a selective beta-1 receptor antagonist or beta-1 blocker, and it also acts as an NO donor. So what does it do? It causes, or as we can say, it aids in the donation, or as we can say, it aids in the increase of the nitric oxide levels in the blood circulation system, and that is the reason we can say it is recommended to give in atherosclerosis. So in atherosclerosis, what does it do? It improves endothelial function and delay of atherosclerosis. So if a person is having hyperlipidemia condition, so hyperlipidemia is slightly different from atherosclerosis. So we can say hyperlipidemia is initial stage of atherosclerosis. So in that hyperlipidemia condition, it improves the endothelial function. So if the blockade of these vascular smooth muscles is taking place, the endothelium function can be maximized, or as we can say the endothelial function can be altered because of the nitric oxide which is present in the cell. So that is the reason, because of the increased or excessive nitric oxide, it causes vasodilation of the endothelium muscle, and thereby it exerts its actions, and that is the reason it is showing delayed effect of atherosclerosis, and it is recommended to give in congestive heart failure in a dose of about 2.5 to 5 mg. So apart from these drugs, there are various other beta blockers also, like cartilol, bopindolol, oxoprinolol and penbutalol. So these are few of the other beta receptor antagonists, and they have very few clinical applications. So most of these beta 2 receptor antagonists have clinical applications in the cardiovascular system, as well as in the cardiovascular system, in order to lower the lipid levels as well as to show bradycardia condition. And apart from that, they show intrinsic sympathomimetic activity. So these drugs are mimicking the actions, or we can say they are showing the stimulation of the sympathetic nervous system, and that is the reason the clinical effects, or as we can say clinical use of these drugs is very less when compared to other beta receptor antagonists.